Hello, everybody, and welcome to this episode of the eGPlearning podcast with myself, Gandhi, and we've got Andy with us as well. How are we doing, Andy?
Yeah, hi there. Not too bad. Love the new intro logo, Gandhi. Sounds like we're on daytime television. Very good.
Yeah, trying something new, and I think that's definitely an appropriate time for us to kick off because we've definitely had something new being discussed today in terms of the potential COVID vaccination program that's been looked at for the country. I mean, this is a hot item in terms of the recent news and stuff, isn't it, Andy?
Yes, and quite unexpected. I'd wondered if the COVID vaccination was going to roll out in a different way, actually. So this is a little bit unexpected, and yeah, I think a little bit potentially controversial as well. Yeah, we don't know all of the details yet. So this episode is very, very speculative, and I think we've even got a health warning to splash up on the screen at some point, so people can take this with a
Do. So absolutely one of the things we're going to talk about. So just to update people, so we're going to be talking about the new COVID vaccination program, and potentially this was meant to be offered as a DES, so a direct enhanced service to general practice. Many of you probably heard the news articles or read them and that kind of stuff over the past few days. For absolute clarity, this is all speculative because the DES has not been officially released yet. It was meant to come out yesterday evening, so we're broadcasting on Saturday. It was meant to come out on Friday, hasn't done yet. But there is lots of information that's been leaked and shown and stuff. We're going to talk about that briefly. We're then going to talk about the actual details of what we know, speculatively, of course, and then potentially the logistics of delivering some of that things. And then finally, we're going to talk about, I guess, our potential views of how we can deliver that. And as a special for this episode, we're actually offering the opportunity for you, our live viewers, because we are doing this live, to actually join us and talk about some of this stuff at points throughout this stream as well. So keep your eye out for that. If you do want to join us, you're more than welcome to do so. I'll be controlling that element of things. If you are watching, feel free to comment. Absolutely. We're keen to know your views and stuff throughout this. And if you're watching us on the replay, shout out to all of you all that are watching us on the replay. Feel free to comment down below as well so we can see those and respond to that and stuff. And yeah, shall we get cracking then, Andy? Yeah?
Yeah, let's get cracking. I suppose those people who might want to be on screen, if they just make sure they've got their webcam and their headphones and things like that ready before we get to that moment. And I think it's just a case of you splashing a link on screen and then clicking it to get them up and running. So people shouldn't feel daunted by that prospect.
So when we get to that point, I'll put a link up on the screen and in the chat that people can use to join us. It takes you through to the back end where you can see us and the stuff, and then we'll bring you on when it's relevant and able to do so. But I guess just to give everybody a summary of what's happened. So for clarity, obviously the news has broke over the past few days that there is plans for general practice to deliver the COVID vaccination. So we're already full swing in terms of delivering flu vaccinations, so seasonal flu. But COVID is obviously there is now a vaccine, or there's two vaccines actually being developed locally for our country to use. And there's plans to deliver this from December. And part of that is to help support general practice to deliver. So they're releasing this as a DES, so direct enhanced service. This is an optional service that practices can sign up to in order to help do it. A couple of things that have come out as a result of this. So this went to the GPC on Thursday and had assent from the GPC. I'm not sure the exact numbers, but I believe about 2/3 of the GPC representatives agreed to it. And then as a result of that, we've fortunately or unfortunately, had some leaked documents as to what this DES actually looks like. As I said, hasn't been officially released. And now we're waiting for more details. Interestingly, the original timeline was that practice had to respond by the 13th of November, which is coming Friday, as to whether or not they were going to deliver the kind of COVID vaccination program and stuff. I'm assuming that those deadlines are going to have to be pushed back a little bit because the release of the information has been delayed. But the media's already got the handle of this, haven't they, Andy?
Yeah, so I've got my screen share. So nice headline in the Sun online today. GPs could dole out COVID vaccine on Christmas Day and Boxing Day to protect millions of Brits. So it's not nice to learn about these things on the front page of the Sun, is it? As GPs, and I suppose they're also probably speculating based on the leaks, but it's possible that this could be a 7-day a week, including bank holidays and weekends, affair to get people vaccinated with the COVID-19 vaccine. And I think I'd say we're speculating, aren't we? So we said I think it's as early as December, so not necessarily from December, but as early possibly as December. I think it's all still very up in the air, and of course it's a very important step in the country fighting and defeating and overcoming the COVID-19 virus, which has caused an awful lot of harm, upset, and health and economic damage. So it's really important that this is done, and I don't think anything that we're saying this morning is contrary to that or to diminish that at all. But I think it's important as a profession that we have these conversations about how things are decided, how things are done, and how practical the plans that are put in place to do these things are, because it's really important that it's done effectively and that what we do works, and that the other important work that we do as GPs can also continue in terms of identifying early cancers, the other vaccination programs that we do, and the other routine but very, very important and vital care that we do. So just wanted to say that we're not seeking to criticize the concept of GPs helping with the vaccination program, but it's just important that these things are done right. So I've said my bit, let's crack on.
Absolutely. So we're going to have a look at some of the information that we have. So we mentioned earlier again that this is all speculative. I'm afraid we're going to keep saying this just because obviously it's information that we've had that we're not sure of. But I think that the main document that I know I've looked at is the GPONline one. So shall we have a look at that, Andy?
Yeah, let's just bring that up. So it's a really good headline summary of the information that they have seen coming out, I think, in terms of leaks about it. It gives a really good overview to some of the main issues. They've scoped out some of the issues that the profession are going to be highlighting. I mean, a lot of how we intend to structure today's discussion is somewhat around that, isn't it, Gandhi? So, but I suppose first of all, the main DES is still awaited. It was due last night, I think, Gandhi, wasn't it? But it's been delayed, as you say. This information was approved by the GPC on Thursday. I think we'll be talking a little bit about that later on. So yeah, shall we start to go through what we believe to be in the DES, so that people can be sort of informed and brought up to speed about what we think is in there? So I suppose the first point is this could take place as early as December. The idea is to use GP surgeries, or not necessarily surgeries, but GP practices or GP organizations like primary care networks for the delivery of the COVID-19 vaccine in a similar way that GP surgeries deliver seasonal flu and other vaccines by way of a DES with payment for delivering the jabs, the vaccinations.
Yeah.
Yeah.
Absolutely. I think that's right to a degree, because obviously general practice is the main route of delivering vaccinations in basically this country. And we have experience of how to do that. Like you said, the seasonal flu campaigns that have gone on this year have obviously been exceptional because it's the largest campaign we've ever had to do. And also it's making sure that we've got continuous information as to which patients have had it, which patients are eligible, that kind of stuff. So there is that significant piece of work that needs to be done to identify the relevant patients, because unfortunately we don't have the capacity or the logistics to deliver this to everybody at the start. We are going to have to prioritize, and that's for a variety of reasons in terms of the amount of vaccines that can be given, as well as actually the number of vaccines available as well. I think the government has been quite clear, not everybody will get the vaccine because it just isn't physically enough amounts of them. So it then comes down to how we go about this. So identifying the types of patients, and I think the initial cohort is going to be the over 85s, because they are recognised to be significantly more vulnerable as a result of COVID, and as well the healthcare professionals, because we need to keep our healthcare services, the NHS and general practice functioning. Otherwise, none of this is going to work as well. So that's the priority. There are some logistical issues that come with that. So how do you that kind of stuff? Yeah.
Now, just say, shall we? Let's summarize some of the key facts. I use the word fact at a stretch. It's speculative. The key speculations. So, so we believe that these are going to come in large vials. I'm not quite sure what this looks like and what the practicalities of drawing up vaccines from large vials that contain 1,000 doses per vial is. But I believe that's how it's going to be delivered, and that certainly for one of these vaccines, that needs to be kept at minus 70 degrees centigrade up until very near at the time that it is thawed and used, and then it has a limited shelf life of possibly a few days. So that's, I think, where this figure of an aim to deliver 975 vaccination doses sort of per site per day. Oh, is it per day or per week, Gandhi?
Per week.
Per week.
So in order to have payment, and we're going to talk about payment a few times, I'm afraid, throughout this. So I know it's a topic people don't like to talk about, but we have to talk about the funding and the resources. But for each site, they will have to deliver a minimum of 975 vaccination doses per week. And yeah, I suspect, and I think Andy suspects the same thing. It's to do with the fact that the vaccination comes in dose vials of 1,000 doses. So it's that needs to be made up. So it's not pre-filled like the seasonal flu one is. You have to actually make it, and like you mentioned, Andy, there is some additional logistical issues with one of them, that it has to be stored at minus 70 degrees C. So that's below freezing. I don't know any GP practice that has a freezer that can do that. I'm guessing there's stuff like liquid nitrogen and stuff that has to be in place to help with this. And I suspect a lot of these are going to be stored potentially at hospital sites or other kind of areas that that needs to be made aware and stuff. So there are logistical challenges in delivering these vaccines in that realm. And if you're trying to deliver it from one site, so I guess one key thing is this is meant to be a PCN delivered DES. So the kind of sites, it's not that every practice across the country is going to be offering this to you. It's going to ideally be, one site in a network. So Andy, I believe your network, was it 4 practices?
No, we've got 8 practices, Gandhi.
Wow. Okay.
So yeah, so I mean, we might talk a little bit more, I suppose, about the practicalities later on. But having gone through setting up COVID hot clinics or CMCs, for single or multiple PCNs and things like that, it begins to feel a little bit more doable than it might have done nine months ago. But it is a significant challenge, and there are costs associated that I'm not sure will be covered by the proposed charges. I don't know whether we want to get deep into that now, or whether we're leaving that for the practical steps bits later. But
well,
it's going to be a challenge.
We've had a comment already. So this is from Savani 26. Stable for 5 days at 2 to 8 degrees centigrade. Stable for no more than 2 hours at room temperature after thawing post dilution if used. If period is 6 hours. 5 doses per vial, 975 doses per pack. So I guess the key thing from that is that you've got to, once it's defrosted, you've got 5 days to use it. And once you've actually made the injection that you deliver, you've got 2 hours to do so before it's ready to be used and stuff. So yeah, there's some logistical issues there, isn't there, Andy?
Yeah, I mean, you can see how. So, I mean, okay, we can probably store it locally in our fridges for the week at the GP practices, and you can see how someone could be making up doses, in the background for someone else to deploy in a sort of production line type mechanism. Really nice to have such well-informed people watching the podcast live. Actually, that's an absolutely excellent and insightful comment. So, thank you very much for that. Yeah, fantastic.
And I guess to echo Kate's comments, so Kate's hopefully mentioned this, there is a lot of unknowns about this, so it does depend on the vaccine that becomes available. There are 2 main vaccines we mentioned, and they have different characteristics within them. And I guess one of those additional characteristics, so we're talking about logistics, is that they need to be given in 2 doses for you to have protection. So this is unusual in terms of the normal seasonal flu vaccination is 1 shot and you're done for the year. In order to have protection, for these vaccines, you need 2 shots, and they need to be 28 days apart, and I believe no more than 6 weeks. So you've got a 2-week window to get people in for their second dose, and you're not protected until you have your second dose. So there are various vaccinations where this is the case. So things like the MMR vaccine, things like the DTP vaccines, you need multiple doses in order to have complete protection. I guess the challenge with this is it's a very short time frame. But also long enough that people can forget, I think, is the key thing. And our concerns is about having the second dose, clearly.
Yeah, and also payment is only made, so it is £12.58 per dose, with payment only given at the second dose or after the second dose is given as well. So, so people not being able to comply and get back for their second dose is going to have a real impact on the amount of funding ultimately received to pay for the project as well, which I think is an interesting decision. Obviously, it's there to motivate people and systems to get people back for the second vaccination dose. But it may cause some underfunding issues And of course, there's going to be a challenge in the process that you set up to get people back for their second jab. I mean, also opportunities, and I'm sure there'll be lots of technological solutions, in order to do that, that some providers might step in and help with. And I think we've got some information from AccuRx later on in the program today, which I think will be really insightful. But people are going to have to think very carefully about how they set up these systems. Particularly, people might have quite good systems as a practice for getting people in for their repeat vaccinations, but this is going to be PCN wide. So there's going to be an element of setting up those systems again at that scale, and those are going to be challenges. But I think if people are aware of those from the outset, then people can position themselves to address them.
Sure. And I guess to talk about some of those points that you mentioned, Andy. So there is meant to be a central booking system. So whether this will run through things like test and trace or other kind of systems is at the present unclear. But obviously we need that information to then flow to the network for them to use that effectively. So then we make sure we get the right patients in at the right times and it all flows logistically. I guess the other thing, so comment by Rani Bathia, is the payment on administration of offering of the second dose. So our understanding from the speculation data is that you only get paid when the patient has had the second dose. So although it's a set amount per vaccination, so I think it's £12.58 per vaccination given, networks or practices will only be paid once the patient has actually had the second dosage. So if the patient has one, they don't get paid. And that has real concerns for many people in terms of how this is logistically possible. Now, we have been told that there are going to be exceptions and in terms of ability for practicing networks to report exceptional situations where that doesn't happen. We don't have any detail as to what that looks like, and that clearly will be with the DES. But yeah, I think that's one of the big things that come. There are a few massive things that can play with the DES that are a cause for concern in terms of logistical ones, and that's definitely one of the lead ones.
Yeah, Gandhi, I'm going to ask you a little bit about the price here. You saw me skipping through my tabs because I did have the vaccination payment information for what we are paid for the other vaccinations that we give, and it's sort of £10 something, isn't it, for the seasonal flu vaccine that we do every year and have established systems for doing, and is a single dose. £12.58 does not feel, given that this is something new and that we need to build a new infrastructure at a primary care network level around it. This does not feel like enough money to me. I'll just put that straight out there, given that things that we use our existing buildings, premises, infrastructure, staff to do, like the seasonal flu vaccine, we're paid £10 per dose. This does not feel like enough money to do it effectively, and I think that that's an issue, particularly given some of the logistical challenges that we've identified, that we might be integrating with a new booking system that is not a system that is integrated with our clinical system. What are your thoughts on the fee?
I'm going to pause that if that's all right, Andy, because I think there's a couple of other things we need to mention that may make that a lot clearer. If that's all right.
Okay, of course.
And in the efficacies of time, I'm just going to rattle through what those are. Okay.
Go for it.
Additionally, from the speculative information, again, this is all speculation, that the networks that are delivering this will have to do this 7 days a week and offer vaccination times between 8 in the morning and 8 in the evening. Okay. So that's 12 hours a day, 7 days a week. There is question marks about Christmas and New Year's and delivery over those periods, and that's partly where the Sun article that we showed earlier comes into play. But there's additional stuff that needs to be here. So in order to draw up the vaccine, you need 2 people to do so. So unlike the flu vaccination, which is open a packet, pre-made syringe, administer, done, it can be done by one person. The administration of this vaccine is 2 people in order to draw it up, because I think Kate mentioned it in the chat, so feel free to have a look at the chat as you're watching us live or if you're watching us on replay. She mentions that actually the way that these vaccinations are done is completely different, so there is more workload that comes into play with it. And then the other one, which I think is one thing that is being slightly forgotten about, is the consent process for this vaccination. So this is a new vaccine, let's be absolutely clear, in terms of how this works. It is a new vaccine. It is relatively untested. So obviously it's only been created for about 6 months, I believe, if that. And the information we have on the implications of the vaccine not 100% clear. So we can't tell you what impact this vaccine will have on you in 5 years' time. No one could state that. We can give you rough ideas based on the studies and trials and stuff that have been done, but there is that element of things, and how this plays with patients' individual health conditions is information we just don't have. So part of the requirement is that a GP will have to do the consent process for patients with this. And that consent process is going to take time. Let's be absolutely clear. This isn't like a flu vaccination, standard seasonal flu vaccination consent that we do, because we know the implications. Most patients have had it before; they're already having it, and we have got good information in terms and confidence in terms of how the flu vaccination works for many patients. We don't have that for this, so that process is going to take a lot of time. So, in order for this to work, okay, going to give you some numbers, and so this is my back of the envelope, Gandhi's, calculating, and I'm more than happy to be proven wrong on this. We have to deliver a service 7 days a week, 8 till 8. So that's 12 hours a day. That's 80 plus hours. I worked out as 5,040 minutes, okay, a week. Minimum payment, you have to administer 975 vaccines a week. So when you work that out, that gives you approximately, for the minimum payment to make this viable, you have to deliver every 5 minutes of vaccination if you're having one injection site. Okay. And the reason why I'm focusing on this is because in order to run one injection site, you need at least one GP for the consent. You need at least 2 other people to administer the vaccination, because you can't use the GP as well, because otherwise they're not going to be able to consent people in between. And one of the other things is that patients will have to be kept on site for at least 15 minutes after being administered the vaccination to keep an eye on if there's any complications, adverse effects, that kind of stuff as well. So you need to have the social distancing in place in order to make this sensible. So realistically, you're going to need about 5 or 6 people, of which one of those has to be a GP. You're probably going to need a nurse or a nurse associate or something else, somebody to do marshalling. Potentially, we're going to need security. There are lots of question marks about the vaccine, and we could, worst case scenario, have protests. That's vaccination sites and stuff. So we're going to need a few individuals. And when you work out 5 minutes of vaccine, number of vaccines that works out in terms of payment, that roughly gives you about £140 per hour of finance that you've got to play with. So to pay 5 people out of a total budget of £140 an hour, I don't see how it's possible, if I'm being honest. And that's based on everybody turning up for their vaccine. That's based on everybody having their second jab. That's based on, so many other things happening. Yeah. So your question mark of, is it enough money? I'm afraid the answer is no. Now,
No.
there's one extra thing we haven't talked about. So there is plans to additional funding to go to the centre services. So I think that there's a talk about 150 million somewhere in the GPONline article going to CCGs or something like that, to help support the infrastructure around some of this stuff. And I know to somebody who's in the public that this may seem like, oh my gosh, they're getting so much money to do this. It's really not. In terms of the funding we would need to deliver this, it really raises, the question mark of how this works. And I'm going to punctuate this by Kate's coming out with some amazing statements here. And this is based on you having the staff available and stopping all of the work in order to do this. So the workforce that's going to have to do this is our existing GPs and nurses and all that kind of stuff and things. And, we are about to head into probably the busiest time ever in healthcare services. We've got COVID, obviously clearly causing challenges in hospital administration, all this other kind of stuff. Winter is always the busiest time in the healthcare service anyway. Finding the workforce, to be honest, many of us are already at our wits' end in terms of just struggling. Yeah. So to your earlier question, Andy, is it enough money? No. Short and sweet.
I thought that would be the answer. That was a longer and much more reasoned answer than I thought I was going to get. And I think your calculations just show that the funding appears to be so wide of the mark that it just clearly isn't enough money. I mean, I think we could all start to think of ways how you might make the system you suggested a bit more efficient, but really you can't. There are some things that you just can't cut the corners on in terms of the GP consent and the practicalities of drawing up the virus. So yes, there's a real issue with the funding. I think to a certain extent, this is going to have to be a system effort. And I know when we were setting up COVID hot sites, in Nottingham, the system did support and help primary care networks with that in terms of finding and paying for sites and security and other things to support. So there will be system support. But even with that, just all you've included in your calculations there are really just the medical staff and the medical effort required. So it does not seem to be enough. I wonder if this is this potentially why we haven't actually seen the document? Are some people panicking that this is clearly just not practical and we might see some last minute changes? This was due out last night and we haven't seen it yet.
So,
Do you think
and
it might change?
we've got this massive disclaimer with everything we're talking about that this is all speculative. I think there may need to be a difference that comes through. Now, how that works, obviously, it's beyond our pay grade. Thankfully, me and Andy, not to figure this all out and stuff. But I think it's from our perspective. I think if we get what we have been leaked to have, and again, this is leaked information, then I can't see how this can work. However, we are going to discuss our viewpoints on how it could work. So that's not to just we're not here to just turn around and say, okay, it's not going to work. Let's leave it at that. Both Andy and myself are generally practical people. We like to see how things could potentially be functioned and stuff, and where that goes. I think before we get to that, we are just going to go through a couple of comments and stuff. So we've had loads of stuff and things happening. So let's have a little look. See, where have we got to? So a couple of things. So James asked the question about, do we know which vaccine and stuff are proposed to use from the stage 3 trials? I believe that now I know there's going to be people in the chat that know this far better than us. There's the Oxford vaccine and then there's the AstraZeneca vaccine, I believe. They are different. I always forget which one is which in terms of which one needs to be kept at minus 70 degrees and stuff. There are some numbers that I've seen a while back and I can't remember them, I'm afraid, in terms of which one is which, but I can't quite remember that. Patrick is reminding us that you can only give it 7 days after the flu vaccine. So hopefully many practices have been really cracking on, got through the seasonal flu vaccinations because there is a time limitation in terms of delivering that. We've covered a couple of these already. Kate's put in, media have a high retroactivity and most people apparently feel awful for a couple of days after each jab and there'll likely be a large fall up in the second take of the dose. Absolutely. And I guess the other one that we didn't mention is that there has been some evidence that shows that people get a temperature after having the first dose of vaccination. And this clearly has implications in terms of self-isolation, because are people having a temperature because they've had a vaccine? In which case, do they need to self-isolate? Or are they having a temperature because they've actually had COVID or another viral illness? And how does that play in terms of things and stuff? So, comments on there. Shani's made comments about the nominated site for the hubs and funding, patient infrastructure, and all that kind of stuff. And workforce will be absolutely essential. Aaron's made another comment about observation included, and it's not. So the observation time is included in the current outline as far as we're aware. So need to be mindful of that. Training being rolled out for clinicians. So we're going to talk about this in the consent bit that we're coming to later, but we've also identified some of the concerns about the consent. What else have we got? What about delivering to those in housebound and care homes? Observation will be harder logistically. Does a GP have to stay on site for potentially an hour or so after delivering vaccinations? If it has to be GP and stuff, then that's a question as well. Does the GP have to be on site? I would imagine so. We're going to talk about consent shortly, so we're going to have some ideas for that things. But yeah, definitely some stuff.
Yeah,
Andy.
Yes, and so excellent comments and engagement this morning as well. Keep those comments coming. That's fantastic.
But yeah, so we were going to talk next about some of the implications of all this. So
controversy. Yeah. Were we going to get controversial, Gandhi, or are we too scared?
Okay. No. Well, okay. So we're talking about controversy a little bit, and I think one of the things that I'm mindful of. So many people know I spend far too much time on social media groups and stuff, and one of the key questions that keeps coming out about this is how did this get through the GPC? To be honest, how did the GPC actually give assent to this? And is the view that the optics of general practice potentially saying no to this more important than general practice actually being able to deliver it? I don't know, that's a question mark that's being asked on various different forums, both in health and generalness and stuff and things. And I think this is a difficult one, Andy. It's a question we don't have an answer to.
It is. I mean, I've seen in a number of places this phrase. GPs have a moral duty to play their part in delivering the COVID-19 vaccine, and I think as we opened up with, really, that's true. I think that's undeniable. But GPs have a moral duty to fulfill the rest of their contract correctly. They have a moral duty to do things safely. It's not just as simple, and to deliver all of the other important care which needs to happen. Palliative care. Those people at the end of life that still need our support. Those people who need their cancers picking up. Those people who present to us with acute, illness that don't go to the hospitals. The important long-term management of long-term conditions. All of these things are actually important, and the system has a duty to use the resource of GPs who are normally good people who are willing to roll their sleeves up and get their hands dirty and do things. But the system has a moral duty to use that resource effectively, and not to blackmail them with moralistic language into agreeing to something which they perhaps feel now understand isn't deliverable. So I think this is a bit of an issue for me, really, and particularly when people start to throw around those sorts of phrases, I start to have a little bit of an issue with it. How do you feel about it all, Gandhi?
I agree. So, I mean, this went to the GPC. We've heard that they've given assent. I genuinely would like to see some sort of information come out about how people voted in terms of specifics. We live in an age of where transparency and democracy is absolute and needs to be. For example, our current election that's also going on over this time period, which is dominated the news, clearly
our election. I didn't get a vote.
The world election, shall we say, considering that
Yeah.
that's how people are probably viewing it. But yeah, the American election is obviously something that democracy and transparency needs to be absolute. And I agree with this in principle in terms of our system leaders, in terms of the decisions they're making. If these decisions are being made based on optics rather than on a feasibility in terms of of what is doable, because as you said, one of the things that unfortunately has happened over the past couple of months is general practice has been absolutely vilified by the media in terms of how we are functioning. Now, a lot of the changes we have made because we've been told we have to make these changes. A lot of these changes we have made to keep people safe, both our staff and the public as well. And because of that, many GPs have been unfortunately vilified, and the systems, all that kind of stuff, and criticism about prioritizing COVID versus non-COVID care and stuff has absolutely happened. We know that unfortunately we've got several time bombs coming our way in terms of cancer care and other kind of things because of all the pausing work that's had to have been done. And this is a concern for many people, and how this is going to work with trying to deliver a COVID vaccination. Absolutely, we know that one of the things that's going to help society and our world state get back to normal functioning is having a vaccination program that means that people can go back and start doing their normal kind of things. But should that be done at the cost of everything else? And as many people keep commenting in the chat, I can't keep bringing them up. I keep saying, where's the workforce coming from to deliver this? And I know there is some stuff that's being done in the background. So they've changed some of the guidance in terms of who can deliver vaccines. So they're trying to increase the number of types of clinicians that can deliver them to try and open that up to more people. I've even heard about training programs to have members of the public be able to give vaccines. Okay, there's a massive question about indemnity that comes into that. And as well for GPs, I am quite mindful of the fact if I am a GP being asked to consent somebody from this, the only way I will be able to do this is if I have absolute certainty that if a patient unfortunately has an untoward event because of the vaccine, that doesn't come back to me because I'm being asked to consent them for something that I don't have the information outside of what we know. So there are massive unknowns with this, and I am aware that I think this will be covered under the CNSGP scheme, so the NHS resolutions and stuff. But then again, we've been told things like this in the past, and individual GPs have then suffered as a result of it. So there is a question mark on terms of how that's going to work and things. So that there needs to be clarity from the centre as to the consent process in terms of the indemnity for those clinicians that are willing to help and do this, to make sure that it's safe for them. And that's a real challenge. I guess when we're going back to controversy, the other one we do need to talk about, though, is the leaks.
Say that again.
The leaks that the fact
The
that all
leaks. Yeah. Yes. So how do we know this information, and why do we know it? And you know something, Andy, there's two sides to leaks. So
Mhm.
there's two ways to see this, I think. So one is it's dreadful that
Mhm.
we that we learn as the profession about things this way, and it is. But also sometimes people within the system who aren't happy with what something looks like leak it, so that people like you and me see it, and the people out
Mhm.
there, and that actually it's revealed for how unrealistic something is, and then the actual announcement of something can get delayed from a Friday evening to another date in the future, and things can shift and change. So there's a few different ways to read into leaks, really, and some of them are good and some of them are bad. And I hope it's the second scenario here. Good
Yeah,
comment from Shani Patel. Yeah,
absolutely. I
leaks
don't.
aren't accidental, and I think that's what I'm driving at here. And I hope we've got a friendly mole rather than an unfriendly mole in this. What do you think, Andy?
Well, this is the thing, is that, the cynic in me would say that this information has been leaked to basically make it so that general practice possibly could not say no, because the overwhelming public viewpoint will now be that general practice is going to do this, so therefore we're going to do it. Again, the cynic in me, and the cynic I think in many of my colleagues, is also they've released a version that looks so bad that everyone's going to turn around and say no, in speculation. So therefore, when they release the official version, which is not as bad but still pretty bad, well, then they can't say yes because it's not as bad as the original version.
So Gandhi, do you remember about just over a year ago there was the
We had these
PCN
exact discussions,
DES leak, that looked dreadful, and it kind of managed all of our expectations down or in a certain direction. And then when another set of specifications came out, which I don't know how, if those have come out first, we might have not been happy with those either.
Mhm.
But we were all very pleased when the second ones came out. So maybe somebody is pulling our strings and managing our expectations here as well, in a way that you describe.
Are we being cynical? Are we being, forthright?
Are we being realistic? I don't
Yeah,
know.
I don't know. But I think there's definitely this element of, there is controversy around how this is gonna be delivered and stuff. And I guess the other thing and this is the other point we wanted to make, so both myself and Andy are PCN clinical directors. We've got an absolute declaration of interest to make with this in terms of, we are potentially gonna be involved in the delivery of a lot of this stuff, and we have been. So we have been involved in system-wide discussions as to how a COVID vaccination scheme will work across our patch and area. That's no secret. Lots of places have been looking at how this will be delivered. There's been loads of discussions about this, and not once has any of this stuff come into play with it. So this is a potentially different way that's being looked at. And I know there's probably been loads and loads of work being done in the background with other system players, so the ICSs, ICPs, all various different things. I'm aware even organizations like RCGP and stuff have been involved in some of this stuff. But it just kind of seems like a completely different place. Now, whether this was part of those structures and we've not been a party to it, that's absolutely possible. We completely agree with that. But I think it's important to remember that there's loads of work that's kind of gone on to deliver this kind of stuff. And
Look at that.
we just so some people in the chat have said, "What about secondary care delivering some of this?" Well, it looks like general practice is gonna be the only place that does it according to the information. What about, having support from ICPs and federations and all that kind of stuff? Well, that's possible, I guess, still within the letter of the DES, but there's very much it's a little prescriptive in terms of how it's done, and that doesn't fit, for example, it doesn't fit with our plans that we were aware of, does it, Andy?
No, so the question is, so have the plans changed, and why have they changed? And I think it's important that we all have to be very careful what we what we say and how we speak about things, really. But I think based on rumors that I had heard before, it sounded like the plans were looking quite different at a certain stage based on rumors. And I know that a staff survey went out to staff in our area, asking them about their availability, their time, and their willingness to work overtime outside of their normal day-to-day GP and other system roles to participate in potentially a vaccination program. And that is, that information doesn't seem relevant for what is now being proposed to deliver it, directly through GP and PCN services. So it's interesting, and it seems like the system perhaps had a number of different ideas at one stage, or a different idea about how this might be delivered, and that's changed, and maybe the cost envelope of doing it this way is lower than the cost envelope of paying staff to do work outside of their normal roles as potential overtime at weekends and evenings. So just you wonder why things change. But then GP services are experienced at giving vaccinations, and there's some logic in asking them to lead, I suppose. But it's just interesting. Any thoughts, Gandhi?
Yeah, definitely. I think, as Kate put it, oh no, sorry, it's gone. Plans are absolutely looking differently. This is a significant change after 4 months of planning. So let's be clear on that. There are people out there that have been spending 4 months planning this, and we've now got a complete different kind of offer. And whether general practice can do it cheaper, okay, let's be honest, general practice does pretty much everything cheaper than everybody else. That's how cost effective general practice is. But does that mean we should do it? I remember in one of the groups having a chat with somebody, and they said that, well, we're going to do it anyway, kind of like in almost a defeatist point of view. And actually, no. Let's remind people this is a DES. This is absolutely optional. Is it that the optics of general practice saying no to doing this is something that will come back and hurt us? Maybe. But then is by doing it more damaging to our general population health in terms of the impact that has on all the other services we're meant to be doing, in terms of the workforce implications and the impact on our workforce? Many of us are already burnt out as it is from trying to work for non-stop for the past 9 months. How's that going to feel? Going through the hardest winter we are ever going to have to face in the healthcare industry, on top of delivering the largest vaccination scheme ever created. Fun times. But
yes,
we're not all doom and gloom, are we, Andy? We are.
No, shall we think practically now about things? Although I must say this, the cost envelope is part of this that scares me. But let's think practically about how we might do this. So
just before we do, one of the things we did say is that we would offer people the opportunity to come in and join us in talking about this. So in order to do that, this is something we've never done before. So we would like to point this out, and we hope this works. If you want to join us live right now, so this is for those people who are joining us live. If you're watching this on a replay, I'm afraid you won't be able to do this. But if you're watching us live, if you go to that website link, and I'm going to put it in the comments as well. So now,
cut and paste in the comments.
Yeah, I can only put a few people on. So if you do want to join us, that's fine. We may or may not bring you on. And we've got a separate chat function. Please, if you are joining us, a couple of things, make sure there's nothing weird in the background and stuff, because you will need to join us with your camera. Make sure audio is okay. And yeah, we will, once we've gone through this next kind of section, we'll bring people on to discuss some of the kind of the logistics stuff in terms of how this could be delivered. But if you do want to join us, those are the links and stuff to join us on screen. And we'll see if this works, and if everybody turns around and says, actually, we don't want to join you, that's fine. And feel free to comment on the stream instead if that's what you prefer to do. That's completely all right. But in terms of logistics, so we've had chats with other organizations and other people and that kind of stuff, and how this may potentially work. So firstly, we want to talk about, I guess, sites and stuff. I mean,
share my picture, Gandhi.
Yes, this is Andy's kind of what you've been doing with flu and stuff, isn't it?
Yeah, this was our flu. This was our flu clinic. So this is just for the practice. But throughout COVID-19, we developed some better links with our building, which has which we're really blessed actually. We're part of a really nice kind of joint service facility, which is expensive, and the landlords have us over a barrel, and that's a different story. I'm sure many people are in the same situation. But it's a great facility, and there's a sports hall on site. And we actually got their permission to use it for our flu clinic this year for social distancing purposes. And pop-up banners are about £30 a pop to make sure patients are all heading in the right direction. You can open up the fire exits. They're big, well ventilated, and you can flow patients in all sorts of ways. So I just started to show a few pictures, really, just So get in touch with your local sports centres. It looked very empty because it was just our practice, but there's lots of potential for how to do things, and there are people going out the back door and through the tennis court. And in terms of our PCN, I could see this facility, which is within our PCN geography, perhaps playing a big role in a PCN based effort to deliver the vaccinations. And you could partition off the sports hall. You could have a holding area where people can sit for 15 minutes afterwards, with a time card stamped at the time they had their vaccination done, and then they can, be allowed to leave afterwards. And there's probably some efficiencies in terms of, doing 8 practices vaccinations all in one place. And I wonder if the ICP could be supportive in terms of facilitating the use of the building, and perhaps some supervisory non-clinical staff, that it might become deliverable at closer to the cost envelope. I just thought it'd be nice to show some of those pictures. I'll take those off screen now. There we go.
And I agree. I think there's potentially a lot more leeway in terms of having this even potentially cross networks. So my network's about 70,000 patients. Yours was 50 something, wasn't it?
Yeah. We're 47,000, but yeah.
Combining those and having one site in between the two, potentially more manageable, particularly with the volume of patients that need to.
That's a very good point, Gandhi. I would just say that's a very good point, Gandhi, because whilst it's a PCN based DES, it could be potentially be done on a slightly larger scale, couldn't it? I think you would just say maybe two PCNs could combine if their geographies permit, and achieve even more economies of scale potentially.
And I think there's options in terms of things like hub working and that kind of stuff. So at this point, I'm going to bring on somebody who does want to join us. So we're going to say hello to Ishani. How are we doing, Ishani?
Hi, morning.
Good
How
morning.
are you doing?
Not too bad. Thank you for joining us, and thank you for being the first person that's ever done this live.
Thanks.
So yeah, I know you mentioned in the chat and stuff about how hub working could potentially work. So briefly, I know you've got some experience with this. Can you give us a rough rundown in terms of what hub working may potentially help out with doing some of the COVID vaccination clinics? I'm going to give you a couple. That's all right.
Yeah, sure. So I'll be very brief. So as a GP and founder of Lantum, I get to see a lot of the extended access utilization data across the country and mobilization of workforce, especially for integrated care systems like our Dorset and Greater Manchester. And what the potential could be is to repurpose some of the extended access hubs that have seen such a massive decline because everyone's switched on digital first or online consulting. So it might be that is a vehicle, because it's already got infrastructure there. It's got, rostering, you've got staff banks, you've got the management support, but then that brings into question payment. If you're using your extended access hub to deliver something, does that mean then you're not getting your £6 a head? And is there going to be clawback? So I think whilst there will be hub services, and some people have already set up, like Connexus have set up their home visiting COVID response service. It's been running for several months now. It's about perhaps bolting onto these, but where PCNs are coming at this quite naive and not even thinking about the April 2021 extended access service that they will be accountable to deliver, I think it's going to be probably more overwhelming for them. And I absolutely agree with the comments about workforce, like where are these people coming from and what's their emotional and professional support? And this isn't just a month kind of moonshot delivery. This is something that has to be sustained. And, say from a Lantum perspective, there are thousands of clinicians who are looking for more work. We've seen a massive dip in locum utilization. So there are people out there. It's just about maybe using technology or tapping into your local workforce to be able to pull this together. But it's not going to be the same for every region, and every ICS is different, let alone PCNs. So if anyone's interested in hearing more, please just give me a shout anytime.
Absolutely, and feel free to check out our discussion we had with myself and Ishani from a couple of weeks back, a month or two back, about how Lantum has a platform that can allow some of that rotoring side of things to work a bit more effectively and things. But yeah, thank you for that, Ishani.
Just to say, we've done some stuff with Greater Manchester on COVID response and track and trace. It's not just about like clinical workforce; it's the whole ecosystem and who you need to bring in to deliver these kinds of things when you've only got less than a month. If we're going live December 1st, we've got under 4 weeks, and yeah, these things can be rolled out within 2 to 3 weeks if you're working with the right technology partners. So
Cool.
yeah,
All right.
that's my bit.
Awesome. Thank you for that.
Thank
And I know
you.
you're probably still joining us in the chat and stuff for further comments and stuff. Cool. Andy, I guess the other one we wanted to talk about, and Ishani mentioned it there as well, which was technology and stuff. So we have had some further supportive information from another organisation that we're massive fans of. So Accurix, I know, have been looking at how some of the logistical stuff in terms of this can work. So I know this is a document that they've said to me they're happy for this to be shared. If you want the link to this actual document to see it yourself, it is in the show notes. So in terms of accessing it and stuff, you feel free to have a look, or you can look at it on screen. And it just talks about some of the logistical stuff that they've been looking at. So in terms of how to call in the right patients. So I know lots of people in the chat currently mentioning about the over 85s and the health conditions and that kind of stuff and how that works. Also, this whole, the big logistical challenge, I think, for many places is going to be this whole concept of calling in patients for their second jab. So the 28-day reminder. I know various platforms have systems to do that. I guess if we're talking about Accurix, they've got their pathway system that automatically allows you to send a message to a patient 28 days later to say, actually, you need your second jab. Have you got it already booked or not? And here's how you do it. That kind of stuff that can easily be shared and things. And potentially other options in terms of how this can work and stuff. I mean, you've had a read of this document, Andy. What were your thoughts in terms of how it looks and what it may cover and stuff?
So the first thought was AccuRx, clever boys and girls, as ever. Really getting ahead of the game and getting information out there, and beginning to adapt their product to help. So my first thought was, okay, that this is really smart and it's really good that they're doing this. I think it reads as a really helpful document, I think, both for general practices and also for system leaders and people even higher up the system who are thinking about how to do this, because it really sort of takes through step by step, the key thing, really breaks it down in terms of how you need to think about this. How are you inviting people in? How are they booking? What are your options, in terms of booking systems, or what do you anticipate things will look like? All the way through to recalling them. I mean, there's just so much in the document, but it's just really helpful to break it. It just breaks things down step by step to really help you design your process. So I think it's written to, obviously they want people to use their product, but it's useful for everybody, even if you don't ultimately use their product. Did you have any specific thoughts, Gandhi?
No, I mean, it summarizes a lot of the logistical issues and how potentially this can be tackled. I was going to make some comments, but interestingly, we've just had Jacob from Accurix join us on the stream. So I'm actually going to bring him on to talk briefly around the document itself. So hopefully you can now all see him. How are we doing there, Jacob?
Morning.
Morning. I know you guys have been really busy looking at it. I mean, compared to yesterday, this document is about 3 times bigger than what I saw. So definitely you guys have been working hard on this. Yeah, can you just talk us through what it looks like and potentially, there's serious logistical challenges of trying to deliver this, Des. And obviously we don't, again, speculative, we don't know the full details. But what are you guys thinking?
Yes, so we originally actually wrote this before all of the news over the past week around general practice being involved in delivery came out, when actually a lot of the sort of leaked stories looked like it was going to be done in mass vaccination sites. Just really sharing a bit, like Andy alluded to, some of those technical logistical challenges that we could foresee, and actually partly trying to make the case for GP practices to be involved in this, because I think particularly with identifying patients with significant risk factors, nobody else is really placed to do that as well as GP practices, and we've seen that with things like the shielding process earlier in the year. So we've definitely, we're sort of advocating for general practice being a part of this. In terms of the actual delivery, what we've tried to really highlight is a lot of the way that, and I think this was discussed earlier, that the way that flu vaccinations are done aren't going to work here, whether it's the 4-week follow-up, whether it's the, some practices doing more of a process, whether it's, extended for consent, and even just local delivery, the logistics of setting up booking between multiple practices for a lot of areas isn't in place, like really sort of quite practical things like that. One of the reasons we feel so strongly about it is an incredibly small difference in uptake is going to have a massive impact in terms of how effective this vaccine is at controlling the spread of the virus. And I think, you know, whatever solution is rolled out, that solution plus the right tech is going to get a, you know, a high level of uptake. And that's everything from identifying the patients, inviting them, minimizing booking friction. So it's not, you know, it's particularly once you get to lower age groups of lower age brackets of patients, it's not a case of like call up, but all the way through to, you know, making sure the second vaccinations work. What happens if someone doesn't attend that? How do you follow up? How do you remind people appropriately? You know, there's a key role to get the tech right. So we've kind of put this out as, you know, not specific to our tech, you know, bits of it are incorporated. We've kind of said this is where we can help, but more what we would see the solution potentially looking like.
Absolutely. And I know going through this document, you know, there's lots of things that I've had in my mind. So, I mean, for me, one of the big issues, the funding's one, but actually it's the consent process is I see as the biggest rate limiting step for delivery of this vaccination. So can we use tech to try and improve that? So, you know, can we use video group consultations as an option to deliver this in the mass elements? Can we have a potential standardized video consultation packet that patients engage with before they have the vaccination that gives them most of the pros, the cons, you know, that kind of consent process? So then when they go to see the GP, actually it's not the GP saying the same thing 144 times a day, which is potentially what we're looking at, but actually that they're just answering the questions that the patient has had. And, you know, clearly having that available in multiple languages, having that accessible and stuff is, you know, going to be really useful to have. So I'd be hoping that's where some of the, you know, the gains can be made in terms of trying to make this process a lot easier. You know, one of the things I had in my head is if this was an absolute had to do, you know, could we use a system whereby we send a message to a patient saying, here's the information about the vaccine. Please click on this link to reply back to us to say that you have watched this, and that's logged within the clinical notes to say that the patient has therefore consented. You know, obviously adjusting the word to make that a bit clearer and stuff, but you know that may help to streamline the aspects and things. And then you can actually, those patients that do have questions, you can send them to a slightly different route in the vaccination process to have those questions answered before they have the vaccine, if appropriate, and stuff from there. I don't know. Those were some of the things I thought about. And Andy, I know we discussed those before we went live and stuff. Was there anything additional you had?
Is that James or me you're asking?
Both Jacob or Andy.
Go on, Jacob. You've got anything to say?
I mean, I completely agree on the consent side. I think there's a lot of neat things you can do with tech here. I mean, one of the big challenges as a supplier is, obviously, we've got teams working on a whole range of other things to, you know, go and focus on this. We need to know that you know, there's going to be a route to getting practice to use this, that there's going to be a you know, suitable budgets or funding, because a lot of it is quite specific to the vaccine. So right now it's a bit tricky because we don't know sort of, if any, you know, sort of what tech is being planned for centrally. But if, you know, if this is a case of going CCG by CCG with some tech, like, it's not going to happen in time. Like the tech can be built fast. Everything was, you know, we can roll things out fast, but the actual sort of procurement of it and implementation of it won't be fast enough. So that's partly why we shared this paper, to try and feed in like where we can help. But it would need to be a more sort of centrally coordinated approach.
Absolutely. Thank you for joining us, Jacob. As I mentioned earlier, if anybody does want to check out that document, the link to it is in the show notes. So whether you're watching this on Facebook or YouTube or wherever, just have a look down below. You'll see it in the links on the YouTube channel and stuff. So yeah, and I know that your team has been very keen to have this shared as widely as possible so that people can be involved with it. That is correct, isn't it? And I'm not going to get shot for doing this.
No, it's yeah, people can read it. We're not sort of broadcasting it, but it's you know, we're trying to be quite transparent as a company in our thinking and so on. So yeah, we'd love any feedback or ideas or reflections people have on it.
Cool. Thank you for your time, Jacob.
Thanks, Jacob.
Thanks.
Yeah, I agree, Andy. I'm absolutely with you on streamlining the consent, and yeah, I think once the information is available, and I think there is talk of some standardized information or process information around the consent. process being made available. I don't necessarily foresee NHS England making a video available, for example, but that's perhaps for the likes of yourself or me or
Which is a
other people
shame, but yeah, according to Kate, apparently
to
this
help.
stuff already exists. So it's just a case of getting it to the right places. As Jacob mentioned, a lot of the stuff is already there. It's just connecting the dots, isn't it? Really. But yeah, I mean, this potentially, like you said, this is something we'll probably end up doing anyway, just to make life easier for everybody, because we love to try and help out with people in terms of doing this kind of stuff and things. So I think we've talked about a lot with all of this, haven't we, Andy? I'm aware we've
Yes.
been talking for an hour now. Time has flown.
People are probably flagging a little bit.
Yeah,
it's important to get R&R, isn't it?
definitely. So, I mean, if anyone does have any comments or additional questions or thoughts, feel free to stick them in the chat right now. We're just going to talk about a couple of other things before we finish off and stuff. But feel free to mention additional things. If you are watching this on the replay as well, thank you for getting to this point and making sure that you've got value from it. Again, check out the links below, because we're going to stick some extra stuff in there and things. But I mean, overall, Andy, what are you thinking? How we are still speculating. Again, we're going to keep reminding that, and we've had the ticker going along the bottom the whole time. Let me ask it a different way. How could this be achievable based on what we know? What would make it more viable?
So I think the funding envelope is tight to unrealistic. And my hope is that there will be a bit of a central rethink that makes this more doable. And I'm wondering if this pattern of leak, manage people's expectations downwards, and then release something that looks a bit better that people will mop their brow and be thankful for, when they perhaps wouldn't have originally. I'm wondering and hoping really that might happen. I think that system support is important, and that good use of that 150 million to support these efforts, is deployed really effectively. I think we both experienced quite good ICP support, I would say, around development of COVID management hubs, in a similar effort, both making project management staff available to kind of coordinate getting everything in place, in addition to providing security personnel and things like that, and paying rent on additional space. Those sorts of things would be really, really welcome to help PCNs deliver it. So I can see a way that it's deliverable. Also, I'd like to see a little bit of space and headroom and air cover for some of the other things that GPs have been told that and PCNs have been told that they have to do and implement in timescales running up to 21st of April next year and beyond. And I think that there needs to be some space created and some wiggle room in those areas as well. These are things that I'd like the GPC or other people who represent us in the system to be pushing for, or to have been pushing for.
I mean, speaking of that, Andy, a quick win for me absolutely is, so one of the things we know is that with the ARS funding for the PCN DES, there is massive amounts of potential underspends going on across various different areas because of COVID. So COVID paused a lot of the recruitment that happened for networks to find people in the additional roles. Very simply, allowing that funding to be used for this seems like a no-brainer to me, an absolute no-brainer. But because it is so prescripted this year in terms of how we can use that underspend, it's actually proving really challenging to find the roles that allow us to do that for a short period of time. Because a lot of those roles aren't the ones that we potentially need. We will need GP time, we will need nurse time to deliver these vaccinations. And those are the two roles that you can't spend the money on. So, if NHS England or the GPC were looking for a quick fix, surely that is a massive thing that could potentially mean that we get funding resources to help deliver, a mass vaccination scheme and stuff. And speaking mass vaccination, again, Kate's just coming out with some amazing stuff here. So she mentioned, please comment about the RCGP mass vaccination document. Unfortunately, we don't have the link from her at this point, but I will. Hopefully she'll send that to me and I'll stick in the show notes for people to have a look at and things. So you can definitely check that out and stuff in terms of further details and stuff. But yeah, how could it be viable? I think some of the logistics need to be absolutely looked at. Like you said, a bit more headspace for general practice. I think there also needs to be the absolute recognition that actually in its current speculative envelope, it doesn't look attainable. Now, clearly, we will see the details of the DES as they come out in the next couple of days, hopefully, and hopefully, it will look a lot more positive. Hopefully, a lot more viable. I think realistically, the only way it's going to happen is system-wide interaction. And I'll be honest, we probably need the military as well. To be honest,
to shift this stuff around and control the protests potentially.
People may laugh at this, but one of the things that I genuinely am concerned about is that we may have protests at these vaccination sites. We've seen this in other countries and stuff, how particular movements and voices have been really vocal in terms of how this can have an impact. And what would happen if somebody was to turn up at a vaccination site protest and it become an unpleasant situation? That's something that needs to be recognized. It's a possibility. And all it takes is for one of those to happen. And we worst case scenario, break into the site, damage the vaccine. We lose the potential to vaccinate several thousand people because of damage to equipment and that kind of stuff. So, that side of things. What happens if one of these vials gets broken, gets left open, all that kind of stuff, details on that kind of stuff needs to happen, and understanding of the implications for that. I know some people have talked about, the network's going to suffer financially if something happens to these vaccines. Do they have to buy them? My understanding is that that's not an issue. That's being covered.
Not seen that.
No,
Gandhi,
it's covered, but there is an additional finance thing that we did want to speculate even more speculatively.
Gandhi, can I just say something about the military? Because so we both sort of smiled, at that, but I attended a few events at the London 2012 Olympics, and it was fantastic. And that was something that the country wanted to make a big national effort and push around. And there were huge numbers of military personnel deployed, at security checks and, supporting guests at the events. That went really well. They were very professional at setting up, obviously, the barriers and moving people and things around and supporting, the other staff that had more technical roles and jobs. And, maybe it's not too much to expect that in a big national crisis and push that, the military might assist with these, with these sorts of things, providing sites, tents. It's interesting that we're not seeing that in a way when it's something that we can deploy for something like an Olympic Games. So I just wanted to reflect that it's not ridiculous, and maybe we should have an expectation that the military will be used to assist with this thing. I'm sure that they would be very pleased to have the opportunity to help. Anyway, but let's move on to what we were going to talk about.
Just to punctuate that, so Kate again giving us a comment about the fact that the military have been involved in this process. They're just not visible at times because of, I'm guessing, a variety of reasons. I mean, the military are involved with the Liverpool scheme at the moment, aren't they, in terms of test and tracing and the kind of moonshot program that's running currently there. So absolutely, our military has been supporting a lot of these efforts. But, is this something that needs to be recognised? You mentioned about payments. So again, this is a speculative thing. It's a rumor more than anything else. So apologies. I know I don't like talking about rumors, but in discussion with some colleagues that have been involved in the GPC, there is a cynical view that there's something in the original contract that states that GPs can't earn over a certain amount extra with the funding envelope of the 5-year contract. And actually, by doing some of this work, does that impact the uplifts for subsequent years that potentially general practice may face, and therefore potentially even lead to a decrease in funding for following years if we do this work? So I don't know the answer to that. I would hope that if that was the case, that's been raised by a GPC. And if it hasn't, please clarify that. Please, because that's a scary kind of information that is currently going around. It may be fake news, absolutely agreeing to that. But I think, there are further information points that we need to know from our system leaders in terms of how this is going to work and function for general practice, and most importantly for the safety of our patients and stuff. Yeah, interesting discussion, isn't it, Andy?
So well, I think we have to await the release of the official DES document, I guess, and then there'll be a further conversation to be had around that. It's interesting. If it's not doable within the cost envelope, I think in many areas it won't happen. It's
and interestingly, I mean, we mentioned last year how things changed with the DES in terms of the network DES contract and everything else. I think it's really going to be interesting to see how much of general practice actually takes up this potential desert in terms of what it looks like and stuff. Clearly, we need the details. It's a really tight time frame, really short. I believe the plan is that practice will have a week to decide this. So at the very least, if anything from our discussions here, practices are, clinicians are taking this board, just keep your eye out open for it and make a decision that's best for you and your patients in terms of delivering care. But we hope that at least this has provided some supportive information. You never know, me and Andy may try and do an additional one before the deadline. We will see. May not be possible considering a lot of the hats, but
Maybe there'll be a take two next week. Who knows?
yeah, well, we shall see. We'll see how it goes. But absolutely, thank you for everybody that's joined us on the chat and stuff in terms of comments. We've really enjoyed having and seeing your comments and things. And thank you for those that joined us on screen. First time we've done that. It's kind of gone all right, hasn't it, Andy?
That was fantastic. I love that. We need to do that more often.
Absolutely. So you never know, guys. You may be able to join us again in the future and stuff. As always, if you do have any comments or questions, check out whichever platform you prefer. Make sure you subscribe. Definitely leave us a like, leave us a comment and stuff. And as always, eGPlearning is here to help save you and your patients time by taking answer your primary care and learning. And we will absolutely catch you in the next episode.